Clearly, in the 20 minutes, I will not be able to talk about each individual technology that is out there, and there are actually so many. So I'm going to dedicate my time to mostly 4 of the technologies that we're using in our laboratory. So as you can see with the new WHO classification and the nuances of the molecular aspects of disease are now being integrated more and more, and every single one of the classifications now has some type of molecular information that we all now have to incorporate into our laboratories, into our tests, and finally in what you have to order on your patients. So it's becoming very, very rapidly an integral part of the diagnostic workup of any hematologic neoplasm and, of course, of lymphomas as well. There is an exponential increase in the knowledge on the molecular pathogenesis, not only on the neoplastic hematologic conditions, but also some of the benign, and over the past 20 years, this just has been growing and growing, so it's hard to keep up. These are now being translated into routine laboratory assays of very, very high complexity. So from a laboratory perspective, you really have to think on how to design your assays so that you can cover that need and also foresee what you're going to need in the near future. All of these new molecular diagnostics techniques are having an impact on the diagnosis, the subclassification, minimal residual disease monitoring on the patient, risk assessment and outcome prediction, as well as therapy selection. But beyond that, there are just so many other uses, the patient stratification, the actual tumor subtyping, as I said, but we're also incorporating methylation and epigenetic changes, microRNAs, on top of the somatic driver mutations and diffusions that you heard already. So there are numerous methods out there, and the question is, well, which one do I use? So there are single gene assays, there are multi-gene panels, there are next generation sequencing panels that are now becoming used in all laboratories, and you can go with whole exome, whole genome, targeted sequencing. And all of these have nuances on the design and the information that you're ultimately going to get. Numerous factors can impact the accuracy and the sensitivity and the specificity of the testing that you're doing, whether you use target enrichment technology, what the sequencing platform, the bioinformatics pipelines. So these are the things that I'm going to talk about. So some of the examples of expanding technologies that are now being used in many laboratories beyond the molecular profiling itself, the mutation profiling, obviously, you need it for the diagnosis of the patient, but the detection of the translocation sites you saw for B-cell lymphomas. But more and more, the MRD assessment, the clonality assessment, and somatic hypermutation is important for the B-cell lymphomas. What kind of information you get from these assays depends on the platform that you're using, and as you can see, there are multiple platforms. But the 2 that are used mostly are in clinical laboratories are the Illumina sequencing and the ion torrent semiconductor sequencing. And there are many types of each individual one of these, and these are the ones that are used in most laboratories. You can go from the most basic that will give you small amount of information to the Hi-seq and Hi-seq X, for example, that now gives you much more information than what you actually need and what you actually can use for your patient every day. And the same thing for the ion torrent platform. So very quickly, so here the Illumina sequencing, for example, is a platform that works by sequencing by synthesis, and what this means is that it's actually an optical system. You're taking pictures of of the sequencing that you're doing. So in here on the left side is, for example, a strand of DNA that is being sequenced, and every time that you add a base when you're sequencing this, you're taking a picture, and you take millions and millions of pictures every time that you're sequencing every single strand of DNA. And so these pictures ultimately go into a location that you have to read it, so you need a lot of bioinformatics support to be able to do this. And again, the problems with a built-in camera and the signal that you're getting are all kinds of things that you actually have to think about. Ultimately, you read the sequences by the location of the signal, which are going to be on your flow cell, which is what you see here. So with a little flow cell like this, you can do about 34, 35 patients at a time in a single assay, and you're getting all of this information that takes a long time to be able to decode. And again, you do it by looking at the pictures that you're getting. The ion torrent, on the other hand, is the other platform. This is not an optical system. This is something that uses semiconductor sequencing technology. So what you're taking are the strands of DNA, and you're passing them through a chip where you're measuring the release of hydrogen ions. So you're basing your diagnosis on current and changes in current. And this has an impact on the kind of information that you can get from the assay, and also the accuracy of the information. So the extent of sequencing that you can do with these two platforms as tools for molecular diagnostics is very different depending on the platform and depending on the assay that you have designed. So you can do whole exome, whole genome, whole transcriptome on something like on Illumina, for example, but on ion torrent, you're doing more targeted enrichment. So an important concept in terms of the targeted enrichment, which is what you clinically are going to use for your patients, because you need the diagnosis in a specific period of time. I can go with whole exome or whole genome, but that's going to take 4, 5 weeks, 6 weeks, and you don't have the time to be able to wait for that if you're actually basing your diagnosis on the molecular assay that you have requested. So the targeted enrichment assays are the ones that you're using clinically in a laboratory, and those can take anywhere from 5 days to 3 weeks, depending on the complexity of the assay. The two major assays that exist right now is the two major categories are the hybrid capture and the amplicon capture. This is actually a very important concept. The amplicon capture, what you're doing is multiplexing a PCR reaction, which is similar to the single gene assays that we have right now, but now you're looking at many, many genes, and you're adding many, many, many primers. This is difficult because sometimes these primers, the more primers you add, the more information you want to get, then that means that you're going to have, some of those primers are going to interfere with the other primer, and then you're not going to get the information that you need. So with an amplicon capture assay, this is good for when you're looking for information on 1 to 50 genes, but really not more than that, because you just do not have the power to be able to get that kind of information. With hybridization capture, however, you can do anywhere from 50 to 20,000 genes in just one assay, but that's going to take a longer time. What you're doing in this case is just taking the DNA from the patient, you're fragmenting it, and you're making libraries from these fragments. What you're doing is you're not going, depending on how many genes you decide to test, what you're going to do is capture only the fragments that you need, and then that reduces the time that it takes for the assay to give you an ultimate diagnosis. So you're capturing those fragments with capture probes, you're then capturing them with magnetic beads, and then only those fragments that you captured are the ones that you're going to amplify and get the sequencing. So now that I got that part over with, the platform and the types of assays that you could get, the amount of information that you're going to get from those assays, as I said, is completely different. So if you go for a whole exome assay, you are able to get information on single nucleotide variants, so the single mutations such as BRAF or KRAS or P53. You can get duplications, insertions, deletions, the fusions, the rearrangements, but that's something that you cannot get from the more reduced panels such as the amplicon capture. So if you need a rapid diagnosis, you choose something that is specific to the mutation that you're looking for or the gene that you're looking for, which will give you a rapid assessment, but it will not give you all the information that you're going to need if you're looking for the structural changes or the amplification on certain genes. So now let's look at some examples now that we talked about this. In our lab, in terms of mutation profiling, we have, now we just rolled out MSK-IMPACT HEME, which is a hybrid capture assay that covers 400 genes. We also have an assay that detects translocations and this is the MSK targeted RNA Seq, which is an Archer assay, and this is a PCR assay that looks for fusions in many, many, many genes. So you no longer have to do individual fish assays, but actually just a single assay that will take care of 48 genes and respective partners without having to know what the partner is. We're developing several digital PCR assays that, while they're not next generation sequencing assays, they are the new qPCR, and this gives you a lot more information than and certainty of the information that you're getting than the qPCR. And then, of course, the clonality testing for the B-cell lymphomas and the somatic hypermutation, which we're now doing by the MSK lymphoclone assay. So this is MSK-IMPACT HEME, and here are the 400 genes. We have a similar panel for solid tumors, and every 6 months we increase the number of genes, at least 60 or 70 more genes. So you can see that, you know, in terms of validating these assays, it takes a long time, but with the amount of information that we have to include every day, this is the way that we have to do it. With MSK-IMPACT HEME, you not only look at fusions, at translocations, small rearrangements, but you're looking at the entire spectrum of mutations and also the amplifications and deletions of the gene. So here, for example, is a hairy cell leukemia with a BRAF mutation of V600E, but you can also see the spectrum of the mutations that may be very important in how you classify that patient and the risk assessment of the patient, and then as well as as an amplification that you can see here. So there are times an assay like MSK-IMPACT HEME takes about 3 weeks to get a diagnosis. This is something that you cannot do with some of your patients, so we have more targeted assays. And the way that we deal with the targeted assays is by making everything into droplets. So we have assays now, targeted assays that are amplicon capture, where you actually do all of your PCR reactions independently, but in a single tube by taking all of the primers, rather than using all of the primers all at once in a single reaction. We divide them into small droplets, so 1 primer per droplet, and we do the same thing with the sample. And we fuse the droplets, and then we can do independent PCR reactions in each one of those droplets. So it's much easier, and then you don't have any interference of one primer with another. So this is good for rapid diagnosis like KRAS, MIghty88, BRAF, P53 that you need for the lymphomas. The other thing that we do with these targeted assays is that we can actually monitor patients post-treatment after they have had a transplant, because we can look at the host and the donor SNPs, and then it gives you an additional information and the proportion of donor and host that you have. So here, for example, is a patient that was transplanted at this point, where the donor, he becomes 100% donor, and then in the relapse of the disease, the donor proportion starts going down while the host proportion starts coming up. But then you're also looking at all of the mutations that were pertinent for that patient. So these are highly valuable with a turnaround time of about 5 days. Now, in terms of the gene fusions are very, very difficult to look at in a highly comprehensive panel because, well, number one, gene fusions, you have many genes that are very promiscuous and they like to recombine with multiple partners. Not only do they recombine with multiple partners, but the break regions of those specific genes are completely different. They're highly variable. So designing a single assay for all of the variations of that specific fusion is actually very, very difficult. So what we have done is we have developed these targeted RNA Seq assays, but we have validated them. And right now, for example, we have the custom heme fusion panel that has all of these genes where you can actually look for the MYC translocations for all of the BCL2, BCL6, and so the very, very vast majority of the things that are pertinent now by the WHO, the new WHO classification. We are validating a much more comprehensive panel, which is the pan-heme panel that now has about 100 genes. But the good thing about this kind of assay is that you only look for the target for the one gene that is most commonly associated, and then the assay itself finds the partner. So then with that, you don't actually have to use a fish specific for the gene, but you can do it for the ones that are most recurrent. And an assay like this one is an assay that can get done very, very rapidly. It takes about 5 days to do. So for the heme malignancies, it's an assay that works very, very well. So this is, for example, a follicular lymphoma with a BCL6 translocation, and this is how the data looks like. By targeting just the BCL6, then you can find the other genes. So there is really no assays that would actually look for this. So not only do you get the information on what are the partners, the more esoteric partners that you wouldn't see otherwise with a FISH analysis, but you also get the specific sequence and the variety of the different fusions that this patient may have, which is usually not just one fusion, but variations, slight variations of the fusion within the same patient. Now, in terms of digital PCR technology, so we talked about this. This is something that is going to replace the qPCR assays. These are assays that give you very, very high sensitivity. So you can go to 1 × 10⁻⁶. You can look for rare, low-level type of mutations, rapid assessment or confirmation of something that you weren't so sure about in any of the other assays. But also the minimal residual disease assessment becomes very, very easy. Including both mutations and fusions, and they get read very similar to what flow cytometry gets read like. So this, for example, is a P190 fusion, and that you can read very easily by just looking at the specific droplets. So this assay is an assay, again, that uses droplet technology. So what you're doing is taking the patient sample and, again, making everything into small droplets, so each of those droplets becomes a vessel where you can do independent PCR, and you can have thousands of independent amplification events with every single sample. What you're doing is now, after the PCR, you're flowing that sample through a capillary, and then you're detecting what droplets have what signal. So if they're positive or negative, if they're negative, you have no peak. If you have a positive, you have a peak, and you just count the number of peaks that are positive, and then it tells you exactly how many molecules have that mutation that I'm looking for in the small sample that you have from the patient. Now, clonality assessment, I think this is the last one that I'm talking about. So clonality assessment, for a long time, we have been doing this with conventional assays, and they have been around for 20, 30 years. These assays give you only one type of information. Well, do I have a rearrangement? Do I have clonality or no clonality? But it really doesn't give you the information, the full information on the clonal population. So now with the new clonality assessment by NGS methods, you allow the identification of the full range of clonal populations, not only the one that is neoplastic, but also the accompanying populations, with a high resolution picture of the spectrum of the immunity that is found in the lymphoid malignancy. You can determine the specific DNA sequence and go look for that sequence later on in future samples. And that's a lot of power that you get to be able to monitor the patients. You can track residual disease at low level or minimal residual disease down to 1 × 10⁻⁶, so 1 in a million. You can actually capture that molecule and know that it's there. And then it can also define the behavior of the malignancy by looking at how the clonal populations increase or decrease with the treatment that you're giving, and also what other populations arise at the end. For the B-cell processes, you can examine at the same time with these assays the somatic hypermutation as a prognostic marker. So this is how the conventional assays look like. So it was just a series of peaks. If you had prominent peaks, then you know that something is clonally rearranged. But you don't get a lot of the information. You have a hint that you have one clone here, and maybe one clone here, but you don't have any more than that. With the next generation sequencing assays, you actually now have the specific sequence of the clone. What is the proportion? What is the mutation? This is the mutation rate, so that you know which clone is somatically hypermutated, and you can track it individually later on. It gives you, again, the full sequence, and it also can plot the sequence so that you know what the usage in general of that malignancy is. So this, for example, is a CLL sample that has 3 completely different clones so it's one disease, but 3 completely different clones that have different sequences, that have different somatic hypermutation rates. So, one of the clones, which is the major clone, which is right here, is unmutated. However, the other clones are hypermutated. And so that is going to tell you how that patient is going to do later and which clone decides to grow faster post-treatment. Whether it is the somatic hypermutated or not, then that is the information you want to hear. In terms of monitoring of the patient, so you can then take that clone and just look for that clone in subsequent samples, every subsequent sample that you have. And I have here, for example, a B cell, an acute leukemia lymphoma, where the patient has 2 different clones that we're looking for, and here are the 2 clones by usage. After the patient gets treated, you actually find a completely different clone, which is not the one that you were looking for, but still is completely clonal. This happens to be the CAR T cell treatment for these patients, so you can actually track the specific sequences of immunotherapy that you're giving. The patient relapses and then has 3 clones, 2 of them which are exactly the same as the one that we had seen before, but now has a completely different clone that is actually gaining advantage. So you can get all of this information from next generation sequencing, and it's not something that you can get with the current assays. So in conclusion, the technology advances are just extremely rapid, and they give you scientific insights into the genetic basis of the hematologic malignancy that you're looking for. It gives you significant opportunities for the molecular diagnostics laboratory to help in characterizing and track the disease in ways that you couldn't do before, and there are multiple testing modalities that you can use, but you have to be very aware that not every test is going to give you the information. So you may be using a test that is not what you actually need to get. So it's important to have that communication with your pathology service to know how you want to track the patient later on and get the information that you need.